Welcome to chapter 14. We're going to talk about the radiologic evaluation of the ankle and foot. So, injuries to the ankle and foot occur with great frequency, and the ankle is considered the most commonly injured major weight-bearing joint in the body. Most ankle injuries are straightforward ligamentous injuries, but however, the clinical presentation of subtle ankle and foot fractures can be similar to that of ankle sprains, and these fractures can be missed on initial examination. Appropriate imaging can minimize delays in treatment that may result in long-term disability and surgery. So we're going to talk about the chapter. This is the chapter outline. So we have, once again, to review the basic anatomy, the routine radiologic evaluations, CT scan, MRI protocols, and then the trauma at the ankle and the foot. Alright, so we'll first start with a review of anatomy. So the ankle joint is formed by the articulation of the distal tibia, here, and fibula with the talus, here. So the distal end of the tibia is distinguished by a broad articular surface, the tibial plafond, an elongated medial process, the medial malleolus, an expanded process at the anteromedial aspect, the anterior tubercle, and a posterior marginal rim, sometimes called the third malleolus or posterior malleolus. The distal end of the fibula, the lateral malleolus, is slightly posterior to and reaches below the level of the medial malleolus, extending alongside the talus. The inferior contours of the distal tibia and fibula combine to form a deep socket or ankle mortise, found here, into which the upper end of the talus fits. This articulation is the talocrural joint, or the ankle joint proper. The foot consists of 26 bones. These are 7 tarsals, 5 metatarsals, and 14 phalanges. The tarsals include the talus, calcaneus, cuboid, navicular, and the 3 cuneiforms. The talus is the second largest tarsal and is the key in transmitting weight-bearing forces from the lower leg to the foot. The body of the talus articulates in the talocrural joint. The superior surface of the body is referred to as talar dome, and the talar neck lies anterior to the body. The talar head articulates with the navicular anterior and the calcaneus inferiorly. The posterior articulation between the talus and the calcaneus is a subtalar joint, and the anterior articulation between the talus and the calcaneus is part of the talocalcaneonavicular joint, the complex articulation, surrounded by one capsule between the talus, navicular, and upper surface of the plantar calcaneonavicular ligament. The calcaneus is the largest tarsal bone, and the posterior inferior aspect is the tuberosity or the heel. A medial process and larger lateral process extends from either side of the tuberosity. The prominent sustentaculum tali is process extending from the medial proximal aspect of the calcaneus, and the calcaneus articulates with the talus and the cuboid. The superior articulation with the talus forms the subtalar joint, and the anterior articulation with the cuboid forms the calcaneocuboid joint. A depression on the surface of the calcaneus, the calcaneal sulcus, corresponds with a groove on the inferior surface of the talus, the sulcus tali, to form the tarsal sinus. The cuboid is located on the lateral aspect of the foot, articulating with the calcaneus posteriorly, the base of the 4th and the 5th metatarsals anteriorly, and the 3rd cuneiform medially. Occasionally, the cuboid will also form an articulation with the navicular. The navicular lies on the medial side. The navicular lies on the medial side of the foot, articulating with the talus posteriorly and the 3 cuneiforms anteriorly. The cuneiforms are designated by number or by position. All 3 articulate with the navicular posteriorly and with each other adjacently. Anterior articulations with the metatarsals form the tarso-metatarsal joints. The first or medial cuneiform articulates with the base of the 1st and 2nd metatarsals. The second or middle cuneiform articulates with the base of the 2nd metatarsals, and the third or the lateral cuneiform articulates with the 2nd, 3rd, and the 4th metatarsals and with the cuboid laterally. For the metatarsals are numbered from 1 to 5, beginning on the medial side of the foot. Each metatarsal is composed of a small distal head, a neck, a long slender shaft, and a broad proximal base. The head of the first metatarsal articulates with the two sesamoid bones on its inferior surface. The base of the fifth metatarsal supports a distally projecting tuberosity. Articulations between adjacent metatarsals from intermetatarsal joints, articulations between the metatarsal heads and the proximal phalanges form the metatarsophalangeal joints. As for the phalanges, the toes or digits are numbered from 1 to 5 beginning on the medial or the great toe side of the foot. And the great toe is distinctive in that it is composed of only a proximal and a distal phalanx. The remaining toes each additionally possesses a middle phalanx. The distal phalanges of the second through fifth digits are usually quite small and sometimes difficult to identify on radiographs. Middle and distal phalanges are not uncommonly fused. So for the divisions of the foot is often divided into three anatomic segments referred to as the hind foot, here, or here. Okay, then you have the midfoot. It's composed of the navicular, the cuboid, and the three cuneiforms, and the forefoot is composed of the metatarsals and phalanges. The hind foot is separated from the midfoot by the transverse tarsal joint, here, or the Chopard's joint. The midfoot is separated from the forefoot by the tarsometatarsal joint known as Lisfranc joint. So you have to know this one, the Lisfranc and the Chopard's, the eponyms. For the ligamentous anatomy, okay, so there are three principal sets of ligaments stabilizing the ankle joint: the medial collateral ligament, the lateral collateral ligament, and the distal tibiofemolar syndesmotic complex. So the medial collateral ligament, also known as the deltoid ligament, this one here, consists of a variable number of superficial and deep bands expanding in a fan-like shape from the medial malleolus to the talus, the navicular, and the sustentaculum tali of the calcaneus. This ligament possesses great tensile strength and is rarely injured in isolation. The lateral collateral ligament are the three distinct ligamentous bands extending from the lateral malleolus to the calcaneus and the talus. So these are known as the anterior talofibular, posterior talofibular, and the calcaneofibular ligaments. The lateral collateral ligaments are injured with much greater frequency than the medial collateral ligament. The distal tibiofibular syndesmotic complex is considered to be among the most important stabilizing structures of the ankle, crucial in maintaining the width and stability of the ankle mortise. This complex is composed primarily of three structures: the anterior tibiofibular ligament, the posterior tibiofibular ligament, and the interosseous membrane, which binds the fibular and distal tibial shafts together. So for joint mobility, the ankle joint is a hinge joint. A transverse axis through the talus follows the dorsiflexion and plantar flexion of the talus and foot in the sagittal plane. Foot motion is complex, and the movement occurring here involves multiple joint and planes. The basic motions of the foot and ankle are the following. So you have the plantar flexion and dorsiflexion, you have abduction and adduction, and supination and pronation. So I think you already know this one, so I won't be emphasizing it more. So for the growth and development, the foot is formed during the 8th week of gestation. At birth, only the calcaneus, talus, and occasionally the cuboid are ossified. So remember the three. The ossification centers for the diaphysis of the metatarsals and phalanges are also present at birth. Ossification centers for the remaining tarsal, metatarsals, and phalanges or phalangeal heads and bases in the distal tibia and fibula appears between 1 and 4 years of age. The tarsal complex there The tarsals complete their development at adolescence, and the remainder of the foot and ankle is fully ossified at 18 to 20 years of age. Although the foot is composed of as much soft tissue as bone at birth, the skeletal maturity of the foot is 90% bone. In normal development, the lower extremity of the 3 months old fetus are flexed, the hips are externally rotated, and the legs are crossed, with the feet plantar flexed and adducted, resting against the fetus' abdomen. By the second trimester, the lower extremity uncross and they rotate, and the plantar surface of the feet come to rest on the mother's uterine wall. Failure of this postural change to occur may cause deformities of the feet to be present at birth. The feet of a newborns will normally appear flat, owing to immature tarsals, muscular and ligamentous development, and a fat pad present on the sole of the foot. The longitudinal arc develops along with ambulatory skills, but persistence of the pronated feet and genovalgum is not uncommonly during early childhood and generally dissipates with further maturity.